right, everyone. So today's lecture topic is obstructive lung disease. And when we think of lung disease, we tend to divide it into two separate categories: obstructive lung disease and restrictive lung disease. Obstructive lung disease means we can't get the air out of our lungs once the air is already in our lungs. And diseases that we talk about in obstructive lung disease are asthma, COPD, and sometimes bronchiectasis gets lumped into this category. Restrictive lung disease, which we'll cover in another lecture, has to do with a lack of being able to fill the lungs, so trouble breathing in rather than breathing out. So let's get into it a little bit. Here are your course objectives. And like I mentioned before, the main topics we're going to be covering today are 1, asthma, 2, COPD, which is sort of an umbrella term that covers both chronic bronchitis and emphysema. And the third would be bronchiectasis, which we're going to touch on very briefly. When we have obstructive air disease, we're mainly talking about disease of the airways themselves. And so we'll go into kind of a little bit of the patho behind it, but mostly the signs, symptoms, and how we diagnose and treat. So asthma. Asthma is something that I am very familiar with, both as a provider in the emergency room and as a patient that has had asthma my whole life. Since I was a little kid, I was in and out of the hospital with kind of weak lungs. I was a scrawny little kid and I had trouble breathing. Anytime I got any type of little cold, it would turn into an asthma exacerbation, and I had a lot of trouble up until high school when I had a really bad exacerbation that landed me in a pediatric pulmonology office, Dr. Hidalgo, who treated me and put me on medications that help prevent me from getting asthma. And so now I'm not walking around with my inhaler like the kid from the Goonies, puffing it left and right. So without going too much more into that, let's talk about some of the general considerations of asthma. So asthma is generally thought of as more of a pediatric disease, but you can actually get asthma at any time in your life. It's very, very common, and you will see this if you're in pediatric clinic, if you're in family practice, internal medicine, or in the ER, urgent care. There's some genetic component to it. We're not 100% sure on that. It's slightly more common in men and male children than female children, and slightly more common in female adults than male adults. And there's a prevalence of this. It seems like it's increased recently over the past 20 years in the United States. It garners a lot of ER visits. So 1.8 million ER visits and 10 million office visits, and also 3,500 deaths. That's nothing to blink your eyes at. That's something that's pretty significant. So you will see this. You have to be able to diagnose it, and you should know how to treat it. Hospitalizations are highest among Blacks and children, and death rates are consistently higher among Black children or young adults, and range 15 to 24 years old. Now, we have the Global Initiative for Asthma, otherwise known as GINA, which is kind of the governing body which do the global strategy for asthma management and prevention. And they meet every few years to discuss asthma management prevention and update the guidelines. And the latest meeting was in 2023, where there were some updates done that we will talk about in this presentation. And basically what they do is they address asthma diagnosis, assessment, management, and exacerbations, and they make their recommendations. So later on in this presentation, we will look at the GINA 2023 report. So, asthma. What is the main pathophys? This is very, very, very broad. We're not patho, but essentially you have problem. It's a chronic airway disorder, and there's 3 things that happen within the airway that cause asthma and their symptoms. One is airway inflammation. Second, which is most characteristic of asthma, is this hyper responsiveness to either an allergen, to cold, to exercise. You get this hyperreactivity within the airway. It kind of starts clamping down, swelling up. And you get reversible airflow obstruction, meaning that the air can get into the lungs, but you have a lot of trouble getting it back out. And like I mentioned before, asthma can happen at any age. One other thing to distinguish is that asthma is a reversible cause of obstructive airway disease. And this helps, one of the things that helps differentiate it from COPD, and COPD is a non-reversible obstructive airway disease. Asthma is reversible. We give medications, it gets better. Okay. We also know that the bronchoconstriction or hyperresponsiveness is within the smooth muscle of the airway. We also get this kind of airway edema and inflammation, which causes plugging and mucus formation within the walls of the bronchioles. I'll touch on this briefly. There is a difference between an extrinsic and an intrinsic asthma. Extrinsic asthma is kind of the one that we generally think about. It's the most common. Usually starts when you're a kid and kind of follows you out through life. It sometimes gets better as you get older. It's a type 1 hypersensitivity. You always think about these triggers, outside triggers like pollens, house dust, molds, cockroach, pets, and all this stuff that patients are exposed to. And you also kind of tend to place it in the wheel of the allergic triangle or Sempter's triad. Allergic rhinitis, that's not Sempter's triad, but allergic rhinitis, eczema, and asthma tend to go together, these types of reactions. And atopic allergic asthma is another way to say it, but I've never heard anyone call it atopic allergic asthma. They just call it asthma. And this one has a strong family history of allergies. So my mom also has asthma. My brother has mild asthma, so it tends to run in the family. Intrinsic asthma tends to develop later in life, and it's a different mechanism than the type 1 hypersensitivity, and it can be initiated or caused by taking aspirin, different infections, cold weather, stress, exercise, and irritants. And in these cases, you don't necessarily have to have a family history of allergic reaction. And you can get some crossover where you have a little bit of both. So the clinical features of asthma, how do we see it? So generally speaking, when a patient comes in, they're going to be coming in with shortness of breath, wheezing, and cough. And when they tend to describe this shortness of breath, a lot of patients tend to describe it as chest tightness, or the sensation like an elephant is standing on their chest, so they just can't quite get the air out well. And it can vary from mild symptoms and intermittent symptoms all the way up to severe, life-threatening symptoms. And it usually occurs pretty quickly within the 30 minutes of the trigger. And at all times do we know what the trigger is exactly, and it really doesn't matter what the trigger is in regards to treatment. But it's just good to know that, if you were exposed to, let's say, pet dander, and you have an allergy to pet dander, chances are you're going to develop that asthma reaction within 30 minutes of that exposure. Symptoms are also typically worse at night. It seems like most illnesses, the symptoms are worse at night. I'm not 100% on what the reason is behind that. But wheezing is very classic of asthma. And wheezing is this musical note. I would advise you to Google it and listen. And it's good to know that not all wheezing is asthma, but the most common cause is asthma. So there's other things that can cause asthma. CHF can cause it, COPD, even certain cardiomyopathies and pleural disease can cause it, as well as lung cancer. But most of the time, these patients, they know they have asthma, they come in, they have a cold, or they have something that's provoked their asthma, and they can tell you that that's what it is, and you can treat them accordingly. On physical exam, you can see this allergic type presentation where they get nasal mucosal swelling and polyps. They tend to have some element of eczema or atopic dermatitis. And on auscultation of the chest, you tend to hear this wheezing or a prolonged expiratory phase. So usually when we breathe in, the expiratory phase is longer than the inspiratory phase. So when we breathe in, it's shorter than when we breathe out. But with these patients, they have prolonged expiratory phase because they're having a more difficult time getting that air out of the lungs. Now, those are the signs and symptoms kind of general of asthma. The signs and symptoms of acute asthma exacerbation, a patient that's having severe trouble, are going to be much more alarming. So the acute signs and symptoms are tachypnea, breathing fast, diaphoresis, wheezing, unable to speak in complete sentences, and then the use of accessory muscles of respiration. So we've seen that when we kind of looked at the respiratory infections with the little babies having trouble breathing. They get tugging, tracheal tugging, they get tensing, tripoding, and all of those kind of things. They also can get this paradoxic movement of the abdomen, so it moves opposite of what you would normally think it would. The stomach pooches out when you breathe out and pooches in when you breathe in. During severe exacerbations, when you listen, whereas we're trained to listen for wheezes, you can actually hear nothing or very faint wheezing because just getting absolutely no airflow. So this is severe. If you see something like this, these are the 1 in 3,500 that tend to die each year from asthma. So how do we diagnose it? I think for the most part, it's a clinical diagnosis. I can see a patient, they usually come in to chronic condition, so they come in over and over again for asthma or reactive airway to certain things. Every time I go outside and work out, I get wheezing, I get coughing, I have trouble breathing. You put the pieces together clinically. As far as the official kind of textbook way to evaluate, it's going to be spirometry, which is part of PFTs, pulmonary function testing. And we will go over this in a separate lecture. The pulmonary function testing or spirometry show an obstructive pattern. So an obstructive pattern starts off with an FEV1 to FVC ratio of less than 0.7, less than 70 or 80% is the cutoff for that. And you'll also see a decreased FEV1. So FEV1 is the amount of air that you can blow out in 1 second. So we know if we're having an obstructive process, it's harder for us to blow out. So we'll have less air blown out. And the FVC is the total amount of air that we can blow out. So you'll see that the percentage decreases. PFTs and asthma, the other things that we'll see, we're going to go into this in more depth, is a decreased FEV1, decreased forced vital capacity, which decreases the percentage. So less than 80 or 70% is generally considered to be an obstructive process. Other things that we can do, because essentially we know that this is reversible, right? We know this can kind of come and go. And when it comes, is usually when we're having symptoms, is not always the same time that we present for PFTs, for spirometry. And so sometimes we have to modify the pulmonary function testing to either provoke a reaction or to help treat a reaction to see if it's reversible or not. So if we have a patient we suspect has asthma, is having symptoms, if we give an albuterol or short-acting beta agonist, we should see an improvement of more than 12% in 200 milliliters. So we should see an improvement, and that will help us confirm the diagnosis of asthma. One other thing is if a child, say, comes in, they're having asthma attacks, but they're not having one currently, they're actually breathing just fine normally right now, you can actually induce an exacerbation by giving this methacholine. And what it does is it kind of causes bronchoconstriction. And in an asthmatic patient with hyperreactivity, this will cause a decrease in the FEV1 of greater than 20%. And you should know these two numbers right here. FEV1 greater than 12% for albuterol, and a decrease by 20% for the methacholine challenge or bronchoprovocation testing. Broncho meaning the bronchioles, provocation meaning you're provoking it, you're making the asthma happen. Here's some flow volume loops. I'm not going to get into that in this lecture, but just for the completeness sake, I wanted to show you a picture here, but I will go into more depth in another lecture. So we said that it's mostly a clinical diagnosis with the confirmation via spirometry, and that's the mainstay of diagnosing patient. Now, spirometry and pulmonary function testing is not is not something that we do in the emergency room setting. If a patient comes in an acute asthma exacerbation, we are not going to do spirometry. This is an outpatient test that we do, okay, when the patient is stable. Peak flow. So peak flow or peak expiratory flow rate is a way for patients to help measure the flow of airflow obstruction. And they have these little monitors, and I have a picture on the next slide, that they can blow into on a regular basis, usually a couple times a day, and it helps them monitor what their baseline is, because each patient is a little bit different, and it helps them understand how their medication is working on a daily basis. This is what they look like. There's little it's not electronic. Maybe they have electronic ones now, but the ones I've had are just a little mechanism here. And essentially you put your lips, create a seal around this area, and you blow as hard as you can. Take a deep breath in and blow as hard as you can, as forcefully as you can, and it moves this little red dial up. So you start to know what your baseline is, and if you have a change in this throughout the day, you can kind of monitor how much change you're having and whether or not you need to be evaluated and be treated for an exacerbation. It also helps you be able to tell how well your medication is working for you, because there's a step up, step down treatment plan, which we'll talk about, and that will help. I personally have never used a peak flow meter. I feel like it's most valuable in those patients that have a really hard time like knowing their body. Like, there's some patients that couldn't tell you if it was worse yesterday, better today. And these are the patients that should monitor this. And you should come up with your patients, come up with an asthma action plan, which helps them know, okay, if something happens, my numbers look like this, I need to do this, and this is when I need to call. And that helps the patient kind of manage their symptoms, since it is a chronic disease. Bronchoprovocation test is what we talked about earlier. Chest x-ray. So chest x-rays in most cases of asthma will be normal. If it's severe exacerbation where the patient is having significant distress, you can get some hyperinflation, but it's not always necessary. Chest x-ray is not as crucial in the diagnosis of asthma as it is in other conditions. A lot of times when patients come to the emergency room with shortness of breath and wheezing and cough, we tend to get the x-ray, helps us rule out other conditions like pneumonia, pneumothorax, foreign body, but you don't need the chest x-ray to diagnose asthma. Now, if a patient's coming in a severe exacerbation to the emergency room, they're having those signs and symptoms of severe trouble breathing, then we should also do an ABG, which helps us to identify how significant their respiratory distress is, because generally speaking, they are kind of blowing off CO2. They tend to have kind of a hypocarbic state, right? So treatment, when we approach the treatment of a patient, we have to classify the patient. So the GINA report mentions 5 important aspects to managing chronic asthma. Number 1 is assessing asthma control and severity. So we need to kind of put a label on the patient. How severe is their asthma? How many times a day, a week, a month are they having symptoms? And really what we're trying to do is take the activity limitations and reduce the risk of future exacerbations. Distinguish between severe asthma and uncontrolled asthma. So sometimes we give patients the highest step 4, step 5 treatment, they don't improve, where we know that asthma should be improving with these medications. And so it's important to assess then, are they using their inhalers correctly? Are they actually taking their medication? Is there something else involved? And if they have a true step 4 or 5 treatment that is having trouble being managed, this is the kind of patient you want to refer to the specialist. What we want to do is, where we love the one-size-fits-all method for a lot of things, really is a personalized pharmacologic therapy for each patient. So the goal is to minimize symptoms, have minimal interference with normal activity, prevent recurrent exacerbations, reduce ER visits and hospitalizations, and maintain normal to near normal pulmonary function. And this is with the least amount of medication necessary to attain these goals. So we don't want to put them on 15 different medications and okay, we got it. We want to put them on the least amount of medication that we have to maintain these goals. And so, like I said, it's a step up, step down. You try to find the right step, the right management for each patient as an individual. You also should consider treating modifiable risk factors. Now, if someone came to me and said, your dog is provoking your asthma, you need to get rid of your dog, I'd tell them, you're crazy, I'll never get rid of my dog. So there's only so much you can do in the means of eliminating modifiable risk factors, but it is a good thing to assess, especially like allergens with atopic type patients. And in some cases, we actually we do allergy testing to see what it is exactly that could be exacerbating the asthma. Lastly, guided self-management education and skills training. So as PAs, we pride ourselves on patient education and what we can do for the patient. And so it is a meaningful conversation to have with parents, the children, or adult patients, how to monitor themselves at home, when to know when to come in. So monitoring peak flow, have a written asthma action plan. And then regular review of the asthma control. So even if they're not coming in for asthma and you're their primary care, you always want to kind of assess like how well are you doing, how is your treatment working, and making sure that they're well taken care of and not falling through the cracks. All right, these next few slides, you're going to have to bear with me. These are the dreaded chart slides. And this is the first one. It's not as bad as it looks if you just take a step back and see what we're trying to accomplish here. So I'm going to draw, if I can. Let's see, red. Let's draw something. So in asthma, we have two different main classifications. So we can have intermittent asthma and we can have persistent asthma. Okay. Within persistent asthma, we can have mild persistent, we can have moderate persistent, and we can have severe persistent. And these are the four main classifications of asthma. And how we classify them is by several different factors which are on this chart. Okay, so first of all, let's look at the intermittent. That's the least bad, I guess, the least problematic type of asthma to have. So with intermittent, we're going to have symptoms less than 2 days a week. We're going to have nighttime awakenings less than 2 times a month. We're going to have to use our rescue inhaler less than 2 days a week. We're going to have no interference with our normal activity. And if we get pulmonary function testing, we should have a normal FEV1 between exacerbations. Okay, so essentially it's very mild, very, very mild. It just comes and goes. Okay, now when we decide to treat these patients, we're going to go with a step 1 treatment. Step 1 meaning the mildest form, mostly intermittent or PRN treatment. Okay, so that is the first classification. So next we're going to talk about the 3 persistents, and the first persistent is mild persistent. Now the worse we get this way, the worse the asthma is. Okay, so next is mild. So in this case, where we had for intermittent less than 2 days a week, now we're getting more than 2 days a week, but not every single day, not daily. We're having symptoms. Symptoms are cough, wheezing, shortness of breath. Okay. For nighttime awakenings, they are having about 3 to 4 a month. Waking up with coughing or trouble breathing, having to do an inhaler or nebulizer treatment. The short-acting beta agonists, more than 2 days a week, but not daily, and not more than 1 time on a day. So that's for the mild. We have some minor limitation, and the FEV1 is greater than 80% predicted, so still pretty normal. Okay. For these patients, we tend to start at a step 2. And once again, we can always step them up or step them down depending on how well they are controlled on that. So that is mild persistent. Next we have moderate persistent. Moderate persistent, These patients are having daily symptoms, okay? And they're waking up greater than one time a week, but not every single night. They're having to use their inhaler daily. They're having some limitation with normal activity. Normal activity is not like running a marathon. Normal activity is like having trouble walking up and down the stairs, having trouble folding the laundry, having trouble, walking to their vehicle in the morning to go to work or go to school, okay? And they are starting to show lung function problems, okay? These patients have greater than 60%, but less than 80% predicted on their FEV1, and their FEV1 to FVC ratio is reduced by 5%. And it's telling you over here on this little part of the chart what the normal FEV1 to FVC ratio is for certain age groups. And with these, you'll want to start with a step 3, and we'll go through the steps, okay? Now, if they're presenting with a step 3, step 4, step 5, usually they're a little bit, it looks similar to like an exacerbation. So you have to use your judgment. In some cases, you actually have to initiate some more aggressive asthma control, at least for the first few days to weeks, like an oral systemic corticosteroid, and then kind of work your way back down. But it's really up to you to assess their current state. The last category, and the worst, is severe persistent. Okay. Now these patients, as you would know, are going to have symptoms throughout the day. They're going to have, 7 times a week, 9-time awakenings. Several times per day they're using their inhaler. And they're extremely limited. They can't do much at all. They're going to have some positive findings on PFTs, on spirometry. And like we mentioned with these, you're going to start with a step 4 or 5, probably including an oral systemic corticosteroid for burst treatment to get them back on track, and then we can taper them back down and step them back down. So this is a very important chart, and it's real easy to test on a vignette, because they can put these kind of symptoms in the history, and then you have to decide what type of asthma they are classified as, and then from there they'll probably ask you to treat the patient. You have to initiate treatment. So I really like this slide. It's a lot, but it's not that complicated. And if you're the type that enjoys Medcomic, I have a slide coming up that will help you out. I'm just going to erase these drawings. I'm not sure if they erase on their own, but so. Moving on. Here's your Medcomic slide. It tries to make it easier to look at so that you can kind of remember, oh, there were 3 suns on the mild persistent, or there were every day on this, right? So this is the same chart. It's just presented in a different way. All right, so as y'all know, this is my 8th year teaching the pulmonary module of clinical medicine. And within my 8 years of teaching, there have been at least 3 to 4 guideline changes on asthma management. And so just keep that in mind as we're moving forward through these next few slides, which are updates via the GINA 2023. And I just want you to know that going up and leading up towards your PANCE exam, there are probably going to be more changes by the time that you get out and are practicing in the clinic, and just keep that in mind. The PANCE exam typically has about a 5-year lag from when a guideline is changed to when they actually test it. So I'm not 100% exactly how much of this material is going to be testable for you, but it is still important to know when the guidelines change and how that affects us and our patients. So we just got finished looking at these really, really nice little slides that showed us the classification of asthma. Now, this classification system is created by the National Asthma Education and Prevention Program, which is separate from GINA. And I'm letting you know that because now let's look at what GINA has changed their classification system to. So this is the starting treatment flowchart for the GINA 2023 updates. So all those things we talked about earlier that GINA recommends, the confirmation of the diagnosis, the modifying and controlling risk factors, comorbidities, inhaler technique, and patient references and goals, this is all part of tailoring that treatment to each individual patient. Now, the flow chart to approaching how we diagnose and treat asthma is, I think, simplified with this flow chart in comparison to the NAEPP's guidelines. But either way, you should probably be familiar with both. So let's start here at the first box. So if we have daily symptoms, waking at night once a week or more, and low lung function, then we're going to start with track 1, which is the preferred track. This is preferred right here, and this is track 2, which is the alternative track. So let's just stick with the preferred track for now, because I think we add too much muddy water, it's going to be more challenging for y'all to understand. So if we have these, yes, that's what our patient looks like. We're going to go to the track 1 preferred, and we're going to start with a medium dose ICS formoterol maintenance and a reliever. So we'll go through the terminology here in a minute with the MART and the AIR. If we had symptoms most days or waking at night once a week or more, then we're going to do a low dose ICS formoterol maintenance reliever. And if we have symptoms twice or more a month, we're going to do an as needed only low dose ICS formoterol. If we don't even have that much, we're just going to do an as needed ICS formoterol. And so you see, this is kind of the step up treatment. So step up, step up, step up. It's just looking at it in a different way. All right. So that being said, here are the GINA 2023 guidelines for the 12 years and up population. As you can see, we still have the same review, assess, and adjust that we've had in previous GINA guidelines. And this is really crucial. It's not just a one-stop shop cookie cutter regimen. It is a constant review, assess, and adjust. For these patients, we can step them up and step them down as needed. So let's focus right now on track 1, which is the preferred track. Now, we need to understand that there is and has always been classically treating asthma a controller set of medications and a reliever medication. So, a reliever is what we use when we're having acute symptoms. So, traditionally, this has been a SABA like albuterol. However, and you can see it still is down here, SABA in the track 2 or the alternative track, but the main difference in the newer GINA guidelines is going to be that the reliever is recommended to be the ICS formoterol inhaler. And as you'll see, this is the same inhaler that we are prescribing for both reliever and controller. And this is really, really important, these updated guidelines. So that being said, we have this reliever as the ICS formoterol. Now let's talk about the controller medication. So for steps 1 and 2, simplified, now there's no step 1 difference between step 2 now. Steps 1 and 2 are also going to use as needed only low dose ICS formoterol. So literally, we have the reliever and steps 1 and 2, which are all doing the same thing, which is way easier for our patients. It's an adjustment for us as prescribers because this is not something we're used to. But now when we write our prescription for a reliever medication, we also have to consider how we are writing it, the same exact medication for maintenance or controller therapy as well. Moving on to step 3, we would now do the low dose maintenance ICS formoterol. So we're going to give it on a routine basis rather than just as needed. Moving up to step 4, we're going to change it from a low dose to a medium dose maintenance ICS formoterol. And then in step 5, which are the worst cases of asthma, that's when we're going to potentially add on a LAMA, or we're going to refer for phenotype. These are going to be managed by the asthma allergy specialists or pulmonology specialists. Okay. That being said, this is the newest guidelines. This is how we should be approaching patients. But keep in mind that this is going to lag. When you're out in clinic and you're seeing patients with your preceptors, more than likely, a lot of them are going to still be using this alternative track, this SABA. In fact, I still use my albuterol inhaler as my PRN medication, even though my controller medication is the ICS formoterol. What's so great about formoterol is that although it is a long-acting beta agonist, it actually has both short-acting and long-acting beta agonist properties. So it works quickly and it lasts for a long time. So it has, in fact, become the number one beta agonist that we are using across the board. Keep in mind that there is an alternative track. There is another way to skin the cat. There's another way to treat patients. And this is more of the traditional way, the way that it has been in years past. So they're not saying it's the wrong way to do it. It's just not the preferred way. So keep that in mind as well. All right. So now let's move on to the next one. So again, this was track 1. We always want to have on board this anti-inflammatory or air reliever, the ICS. And this for steps 1 and 2 is an air only. And if you're wondering what air means, I'll go through that in just a second. Here's your track 2. Again, we are still recommending the air, the anti-inflammatory reliever, in addition to the SABA. But remember, this is just the alternative track. So definitely, if we were going to test on any of this, we would try to stick to the preferred track. All right, here's our terminology. So air, a anti-inflammatory reliever. Okay, that's our air. That's going to be our ICS formoterol or our ICS SABA. Remember that ICS formoterol is the recommended. And this is going to provide rapid symptom relief. And it also has that little dose of ICS to keep the inflammation down. It's going to reduce the risk of exacerbations compared to a SABA alone. Okay. Now, regimens with ICS formoterol and anti-inflammatory reliever, as needed, only ICS formoterol is air only. So that's for steps 1 and 2. And then we have what we add on as the MART, okay, MART, which is the maintenance and reliever therapy with ICS formoterol. And so with the MART, they call it SMART treatment because the S was technically supposed to be coming from the brand name of the medication, or sometimes they use the S to represent a single inhaler. So it's considered SMART therapy. But basically what we have is a low dose ICS formoterol used as both the maintenance and for reliever. Okay. All right, so we just covered the 12 years and up chart. This is the six years through 11 years chart. And you can see there are some very minor differences in the step up, step down treatment. For my test for ICM purposes, I am not going to test you on this. This is way more pharmacology than it is clinical medicine, although you are the one that's writing the prescription. So you are responsible for knowing this, but I am not going to distinguish. If I test you on anything for treatment, it's probably going to be in the 12 plus category. But you can see here for reference the difference in how we would approach an initial controller treatment for the 6 to 11 age group. And this is the GINA 2023 recommendation for the 6 through 11 age group. So again, those are the different stepwise treatments. And I'm going to leave this here for you to take a peek at. Again, I'm not going to test you on this for clinical medicine purposes, but you can see that we are moving away from some of our previous recommendations, and these are the new guidelines we should follow. Now, there is a separate recommendation for children 5 years and younger. And again, this is a little bit more complex, not something that I will test you on, but here it is for your reference and for thoroughness sake. So that being said, these are the new guidelines. Chances are they're probably going to change in the next few years. But for now, this is what we're going with, and I just wanted to provide you with those updates. So this is more farm. I'm going to keep it very, very simple. These are the different treatments of asthma. Okay. There's probably more than this, but I'm going to keep it simple because this is ICM. So inhaled beta agonist, you have your SABA or short-acting beta agonist, which is albuterol. Those are used for acute attacks and rescue. Remember, now they are considered second tier for acute exacerbations. It works really quickly, and that's what's so great about them is you get a few minutes and it lasts 4 to 6 hours. We do use this a lot also in asthma exacerbations in a way of nebulizers. Okay, long-acting beta agonists like salmeterol are the long-acting versions of the short-acting beta agonists, and they help a lot, but like I said before, we don't use them by themselves. Inhaled corticosteroid for moderate to severe asthma. Inhaled corticosteroids, you can do them by themselves, or you can do them in combination with a long-acting beta agonist. Systemic corticosteroids, the ones you take by mouth or get injected, are not used routinely in chronic asthma maintenance therapy. What we give it for is usually prompt control of asthma as what we quote unquote call a burst treatment, and that's how we treat acute exacerbations. Anticholinergics have some use in asthma. They're not as widely used as they are in COPD, but we would use ipratropium bromide to help reduce the rate of hospital admissions. We usually do atrovent, so ipratropium atrovent and albuterol. They call them A/A treatments. And usually if a patient comes to the ER and they're having severe trouble breathing, we give them 3 back-to-back A&A treatments, albuterol and atrovent, and monitor their progress. Leukotriene modifiers, I'm sure you guys are talking about that in pharm. It's not as efficacious as inhaled steroids. We don't see them as often being used, but you can use them, as well as these cromolyn sodium and unicromal sodium. Don't use them as much, but can be used, and it's only for prophylaxis, not for rescue therapy. Now we're using these monoclonal antibodies. We can use them. There's a lot of newer medications that are being used in severe cases of asthma, but these are really monitored by pulmonologists. And last but not least, vaccination is very important in patients with respiratory disease, especially asthma. They should receive the Pneumovax or the pneumococcal vaccine, and they should also receive their yearly flu vaccine and COVID vaccine, of course, as well. So that what we've been talking about up to now is more outpatient management of different types of asthma, but there's a difference between that kind of management, like preventing stuff, and the acute asthma exacerbation. An acute exacerbation, the workup is completely different. It's focused on whether the patient needs to be admitted, intubated, or we can treat them and street them. And during an asthma exacerbation, the patient tends to be hyperventilating. They can have trouble breathing. This is not the time to do PFT spirometry. We can use peak flow, although I've never seen it be used. I've seen it in textbook world. They ask what we can do to assess for their function. And peak flow is easy to do. It's quick. But I've never personally seen it on the street, okay? The main goal is to stabilize the patient. We're protecting the airway. We're assessing the ABCs to see if the patient needs to be intubated and what we can do to prevent respiratory failure. Okay. In these cases we mentioned, we would get the ABG, probably a chest x-ray, and the treatment we're going to give them is an inhaled beta agonist. We're going to do it via nebulizer, and we're going to give them that plus or minus ipratropium or Atrovent. We're also going to give corticosteroids, whether they be IV, IM, or PO, depending on the patient. If the patient is going into what we term status asthmaticus, where they are refractory to these treatments, then we can consider giving them IV magnesium. We also give them supplemental oxygen between treatments. And if they have severe exacerbations with the suspicion of infection that's precipitating the exacerbation, we give antibiotics. So patients look really sick, like we talked about initially. They're severely tachypnic, diaphoretic, wheezing, using accessory muscles, and the whole like. Here is your book's chart. Your book's chart is a little bit more inclusive. So these are different classifications of exacerbations. This is different from the chart we saw where we were terming intermittent, persistent, mild, moderate, severe. This is exacerbations. And so this is kind of taking into account how patients present when they're exacerbating. I don't know that you need to be able to assess all of these, but you should kind of have an idea. I think it's kind of common sense. But, if we just relied on our brains to make diagnoses and know what to do with patients all the time, we'd have a lot of variability from provider to provider. So it's nice to have these charts that help remind us what exactly is the different classifications and how we should treat patients. Here are some algorithms from your book. Again, I don't expect you to memorize these algorithms, but you should kind of read through them and they make sense when you do. So this is when a patient is presenting with an acute asthma exacerbation to your clinic and how you should proceed. And this is what you should do when they present to the ER. And it kind of takes you through how you should address the patient, how you should decide whether they need to be intubated or not, and whether or not they stay in the hospital or they go home. So I like these algorithms. Like I mentioned before, I love algorithms. They help me make better decisions for my patients. Last but not least, acute severe asthma is also termed status asthmaticus, and similar to status epilepticus, it is the most severe form of asthma, irresponsive and refractory to repeated courses of treatment. These patients are pending respiratory failure and they require immediate attention treatment. They get steroids, they get nebulized treatments, they get magnesium a lot of times, and they get admitted, sometimes intubated. So if you recognize that term, that's where it's coming from. We don't always use it. We usually use this acute severe asthma. But similar to the chart that we just saw, oops, I didn't mean to do that. Similar to this chart we just saw, it's going to be these really bad ones here. Pending respiratory arrest. All right, this is where I'd stop and ask if you have any questions. Maybe I'll give you a question or two on your Panapto lecture right here. on to COPD. So we said in obstructive lung disease, we have asthma and COPD, which are the two main categories. Now, COPD stands for chronic obstructive pulmonary disorders, and it is an umbrella term. It is an umbrella term for chronic bronchitis and emphysema. Those are the two subcategories underneath the umbrella of COPD. It's common, it's mostly preventable, and it is persistent respiratory symptoms, airflow limitation, and it's mostly due to cigarette smoke, right? We have already said cancer was mostly due to cigarette smoke, and COPD is mostly due to cigarette smoke. If the pull module doesn't make you want to never smoke again a day in your life, I don't know what will. Symptoms usually include cough, dyspnea, sputum production. We're going to go a little more into detail on this. It's a major cause of chronic morbidity, third leading cause of death worldwide. That's pretty significant. And like we said, most causes are due to cigarette smoking. And we'll talk a little bit more about how this can be prevented, how we can try to modify it once it starts. But unfortunately, in most cases, patients who smoke don't tend to quit. And so progressively becomes more and more disabling. For patients in their 40s through 60s is kind of when we see it. And yep. So the GOLD has their own global initiative for chronic obstructive lung disease. That's the equivalent of GINA for asthma. So they usually present 5th or 6th decade of life depending on how much smoking they've done. The more you smoke, the worse you can be with COPD. Symptoms have usually been present for about 10 years or more at a milder level, and just kind of progressively getting worse and worse and worse and worse. If you can stop smoking, you can actually reduce the decline in lung function. So you can you'll never be back to normal, but you can get better. You can improve a little bit if you stop. Initially, dyspnea is only noted on heavy exertion, but as the disease progresses, it can start happening at rest and even with mild activity. Okay. Usually, there's two main patterns of COPD. We have the chronic bronchitis, also known as the blue bloaters, and we have the emphysematous patients, emphysema, which are known as the pink puffers. And we'll go into, there's some charts I have that kind of differentiate the two. In most cases, you get kind of a mixture of the two. It's not always just, oh, that's a pink puffer, or oh, that's a blue bloater. You kind of get overlap of the two different types of COPD. The hallmark of COPD is the acute exacerbation. So just like asthma can have acute exacerbations, COPD has them as well. They get increasingly dyspneic, increased frequency of cough, sputum production, and it's usually brought on by infections. Okay, let's see what else. Okay, so here's again, chronic bronchitis are going to be your blue bloaters. Emphysema are going to be your pink puffers, and like I mentioned before, they tend to often coexist. So it's rare that you just get one or the other. However, on vignettes, they like to kind of classify them. Well, this is a pink puffer, this is a blue bloater. And I have some pictures of what they look like. This is just a really simple chart that I had. This is the chart from your book. It's a much more in-depth chart differentiating pink puffers and blue bloaters. I'm going to keep it really simple, okay? I'm going to use MedComic, okay? Chronic bronchitis is a clinical diagnosis, meaning that you don't need anything other than these criteria, which are daily productive cough for more than 3 months or more, or cough for 3 months or more in the last 2 consecutive years. Okay, so you have to have those symptoms to be classified as chronic bronchitis. Like we said before, it's usually seen in context of a chronic smoker. They tend to be bloaters, right? Big. They tend to be overweight. Blue, because they're cyanotic, they tend to get a lot of shunting of blood away from abnormal lungs, and so they don't get well oxygenated. You have increased amount of hemoglobin in the blood because the body's way to compensate for not getting enough oxygen is to try to create more carriers for oxygen. So you get more hemoglobin just waiting to carry some oxygen, but the problem is that the oxygen is not coming from the lungs into the bloodstream. You also tend to get some peripheral edema, rhonchi, and wheezing. So that's the blue bloaters, that's chronic bronchitis. Now, emphysema is a pathologic diagnosis. And it doesn't mean that we get a biopsy on every patient that has emphysema, but it's a destruction of the air spaces, of the terminal bronchioles and alveolar spaces. You get tissue destruction, okay? Tissue destruction. This is in the, chronic bronchitis is in the airways. Emphysema is destruction of tissue. So usually these patients they're more thin, they're older, they're pink puffers, so they kind of have this kind of a reddish coloration to them. They tend to purse their lips and blow out to try to get air out of the lungs easier. They also have this barrel chests, so their chest is enlarged from hyperinflation. They get flattened diaphragms. And they have a lot of trouble breathing, these patients. They kind of, you can see this patient has his hands on his hips, kind of leaning forward and blowing out with pursed lips. Here's some other pictures in case you like these better. This is your blue bloater. Again, clinical diagnosis, sputum, productive cough of sputum at least 3 months per year for at least 2 consecutive years. Okay, and this is from inflammation in the airway. Then we have emphysema, the pink puffer with the barrel chest. This is permanent enlargement of air spaces due to terminal bronchioles and destruction of alveolar walls. So remember how I mentioned before, the alveoli are these little clusters of grapes at the end of our airways. And because each grape has its own little wall separating it from another alveolar space, you get a lot of surface area for transmission of oxygen from the bloodstream, from the lung into the bloodstream. So lots and lots of surface area. If you took all of those little tiny alveoli, those little spaces, and you spread them out, it'd be the equivalent of a tennis court. So we have tons and tons of space for oxygen diffusion. Now, when you have emphysema, we said this is parenchymal disease. It's destruction of those alveolar and terminal bronchial walls. And what happens is, where you have all those walled off alveoli, they start to coalesce, you get destruction. And when that happens, you lose the elasticity in them. They become kind of these larger kind of pockets instead of these little clusters of grapes. And that reduces surface area for oxygen exchange. And so whereas we would have a complete tennis court's worth of oxygen exchange space, with the destruction of the tissue, you get less and less and less. And that's why these patients have such a hard time maintaining their oxygenation. So we said, don't smoke, okay? 90% of COPD cases are related to smoke. Some other less common cases are going to be due to alpha-1 antitrypsin. And the risk, you don't have to have smoking history to have COPD due to alpha-1 antitrypsin deficiency. But if you smoke and you have alpha-1 antitrypsin, double whammy. Also, there's some environmental factors and chronic asthma, but I've never really seen that. It's usually separated, and especially on a test. Clinical features, we kind of mentioned it already. Usually you're going to have cough, sputum production, dyspnea. And as the patient progresses, the dyspnea will become more at rest with less and less exertion. A lot of patients avoid exertional dyspnea, so they tend to lead pretty sedentary lifestyles, and that can be problematic as well. Signs. So when we see them in the clinic, they have a prolonged expiratory time. We take a deep breath in, and then when they breathe out, they take forever. They can't get the air out of their lungs. So they have prolonged expiratory time. You also tend to have these end-expiratory wheezes when you have them breathe out forcefully. And some inspiratory or expiratory crackles. The inspiratory crackles are from the alveolar collapse. You get them opening back up. They kind of snap back open when you take a deep breath. And that helps open them back up. You can also see all these other signs and symptoms. And one of the end results of this is going to be cor pulmonale, which we have a lecture on coming up. Here's some key points in history taking. I think we know these. So the main definitive diagnostic test is going to be spirometry, same way we had with asthma, although it's not something that we would do in an acute exacerbation. If they came to the ER and they're hard-headed folks that never go see their doctor and it's the first time, we're not going to stop the treatment to do spirometry in-house. This will be something that's done on an outpatient, or if they get admitted to the hospital, they can do their PFTs after the patient is stabilized. You're going to see an obstructive process. So the FEV1 to FVC ratio is going to be less than 80% of predicted value. So we use the FEV1 to tell us the severity of the COPD. And you can see the less percentage of FEV1, the less amount of air that they can blow out in 1 second, the more severe the disease is. Other things you see, which we'll mention now, but we'll talk more about in the PFT lecture, is because these patients get a lot of air trapping, they tend to have an increased total lung capacity, and they have trouble breathing air out, so they have an increased residual volume. So the residual volume is the amount of air that's left in the lung after you breathe out completely. And because they get air trapping, they get residual volume. Because of hyperinflation, they get increased total lung capacity. Let's see. They also get a decreased vital capacity. Here's all those flow loops. Like I said, I'm not going to go through this right now. I have a separate lecture on that. But just for the sake of thoroughness, I put them into this presentation. How do we diagnose COPD? Well, we already talked about spirometry. We already have a suspicion in patients that are smokers, mostly clinically suspicious. Chest x-rays, they're not good at diagnosing COPD. They can be very nonspecific, and you won't see a whole lot of changes on the chest x-ray until you have severe advanced emphysema. And that's when we see the hyperinflation, the flattened diaphragms, the enlarged retrosternal spaces, and the diminished vascular markings. So what we use chest x-ray for is mainly in the setting of an acute exacerbation, and that's to help with ruling out pneumonia or pneumothorax. ABGs are also used in the acute setting. Because these patients get a lot of air trapping, COPD tends to lead to chronic respiratory acidosis with a metabolic alkalosis compensation, which we will also cover when we do PFTs. We'll cover acid base. So some of the complications of COPD: acute bronchitis, pneumonia, PE. You can get some dysrhythmias and trouble with concomitant left ventricular failure. And so you have a lot of other things that can happen. You can also get COPD is the most common cause of pulmonary hypertension. So we'll talk about that in another lecture as well. You can get spontaneous pneumothoraces, and you can get hemoptysis. Treatment of COPD is guided by the severity of symptoms in the presence of exacerbation of stable symptoms. So 3 main ways that we can identify high-risk COPD patients. FEV1 less than 50%. Remember, we use FEV1 to classify. More than 2 exacerbations within the previous year, and more than one or more hospitalizations of COPD. So these are the patients we need to be more aggressive on treatment with. The best thing that you can do for your patient of COPD is to try to convince them to stop smoking. They say just mentioning stopping smoking can help decrease the amount of smoking in patients, can help 5% of patients quit if you just say something about it, if you just encourage them to quit. Now 5% is not much, but it's more than nothing. There's other things you can recommend, like treatment programs, chewing gums, and other things that help, medications that help patients quit. Disease progression is accelerated by continued smoking and can be greatly slowed by cessation. So a non-smoker, this is their FEV1, and you can see how it plummets with age. So that's, if you stop, you can change the curve. You can change your curve to a better curve. Okay. It does not reduced your level ever back to what you would have if you had never smoked. You can see this curve doesn't shoot back up to the non-smoker level, but it does improve, okay? We still want to encourage it. It's the best thing we can do. The other best thing you can do, and the only therapy we can give shown to improve survival, quality of life, and improve the natural history of COPD, is giving oxygen when a patient is hypoxemic. And there are some criteria for what makes a patient hypoxemic, but it is giving supplemental oxygen is the only treatment that's shown to improve survivability and quality of life in patients with COPD. Some patients need continuous oxygen, others just require it when they're sleeping or exertion. And this is something that's going to be taken care of by the internal medicine or pulmonology physician. Let's see. There's also other treatments that can be done. Remember, it's non-reversible, meaning that there's no medication that we can give that's going to improve the symptoms, mostly just helping out, like helping the patient manage their symptoms. A pulmonary rehabilitation is going to be education, exercise, physiotherapy, breaking up the mucus within the lungs. We want to really get them to a more functional level. We get them walking more, able to perform their ADLs, and it helps improve quality of life. There are multiple studies that show that it improves exercise capacity, it decreases hospitalizations, and it increases the quality of life. So we do want to do this pulmonary rehabilitation as much as possible. Now, getting into the more pharmacologic treatments of COPD, we know that bronchodilators really help in reversible asthma, but in irreversible COPD, they are not as helpful with treatment, although we do use them. Okay. We also, the mainstays of treatment are inhaled anticholinergic drugs, so the ipratropium, we use that. We use inhaled beta agonists like albuterol. We also use combinations of inhaled albuterol and ipratropium. Those are the A and A treatments that I talked about. And also inhaled corticosteroids are used. Kind of as a fourth line agent behind those three main ones, it's going to be theophylline. Theophylline can be toxic, or you can get too much of it in your system, and so we don't use it often anymore for asthma as we did back in the day, but we do still use it in COPD as a fourth line agent. And I'm sure you'll go through these therapeutics a little more in your pharm class. Other things we can do, vaccination. So same vaccines we should get, annual flu vaccine and the strep pneumo vaccine. Other things we want to do is prescribe antibiotics when they're needed. We're going to use antibiotics to treat acute exacerbations. We're going to treat acute bronchitis and prevent acute exacerbations of chronic bronchitis. If you'll recall, back in the pulmonary infections lecture, I mentioned acute bronchitis. Now, acute bronchitis is different from the chronic bronchitis of COPD. So that's really important to differentiate. Last but not least, we can do surgery on patients. It's very select patients. You have to weigh risks and benefits and really think about. It's not something that you as a PA in general practice would most likely have to consider. But you can do things like partial lung resections and lung transplantations. And with lung transplants, if the patient can exhibit smoking cessation and you can do a lung transplant, it can be beneficial. And some of the requirements for lung transplant are severe lung disease, limited activities of daily living, exhaustion of medical therapy, done everything. They're ambulatory and they have potential for pulmonary rehab. The life expectancy has to be limited without the lung transplantation, meaning that they have to be kind of pending death if they don't get the lung transplant, and they have to have a good social support system. 2-year survival rate after lung transplant on COPD is about 75%, so not too bad. There are some classifications of COPD, and I don't necessarily need you to know these, but essentially we start with the three medications we talked about initially, or two or three of the medications, and then we kind of can step up. If they have severe disease, especially chronic hypoxemia, we're going to give the oxygen, rehab, and the other triple inhaler therapy. Okay, so just like with asthma, we have regular old asthma, and we have asthma exacerbations. Same thing with COPD. One of the hallmarks of COPD are these recurrent exacerbations. And one of the main treatment goals for COPD patients is to reduce the number of and severity of exacerbations that they have each year. And it's pretty much inevitable. Patients will have these exacerbations, but we want to try to limit them. Essentially, they get worse. They have increased dyspnea, they have increased sputum production and cough, and it can lead to respiratory failure because remember, these patients' lungs are not great. And so these patients can get sick pretty quickly. They might have to be intubated, and it can be potentially fatal. You do kind of the same things we've already talked about. You give the bronchodilator treatment, usually with anticholinergics. You also start them on systemic corticosteroids, so IV steroids usually, as well as antibiotics. Supplemental oxygen is also given. And if they get bad, you might have to step them up to non-invasive positive pressure ventilation, which is like CPAP or BiPAP. And then, of course, if they're still not oxygenating well, even with the CPAP or BiPAP, then we have to, escalate them up to intubation and mechanical ventilation. Oops, I did not mean to do that. I don't know what that was. All right, so when do we admit these patients with COPD? Well, they're patients that have severe symptoms that are worsening, and they're failing outpatient therapy, worsening hypoxemia, hypercapnia, peripheral edema, or change in mental status. They have to have inadequate home care, or they can't have inadequate home care, and they can't sleep, maintain nutrition or hydration status because they just can't breathe. And also, we have a lower threshold for admitting patients with high-risk comorbidities. When they are admitted, we usually start with chest x-ray, get an ABG, basic labs. We give the double therapy inhalers, but really it's nebulized medication. And then we give systemic corticosteroids, antibiotics, supplemental oxygen, and we do the non-positive pressure ventilation. So having COPD is not a good diagnosis to have. Like I mentioned before, most patients tend to continue smoking. They don't change their lifestyle. Thus, that kind of graph where we saw the angle of deterioration, it continues to deteriorate over time. The degree of pulmonary dysfunction at the time the patient is first seen is an important predictor of survival. So the median survival of patients with an FEV1 of 1 liter or less is about 4 years. There's also this Bodie index that we can use to help us kind of see where they are and kind of predict death and hospitalization. And then there's comprehensive care plans, and they can help with oxygen, pulmonary function, bronchodilators. But like we mentioned, the only thing that's going to affect the natural course of COPD is going to be supplemental oxygen and smoking cessation. And last but not least, at the end of life, when patients have COPD, it's like you're starving for oxygen. So it can be quite uncomfortable. Patients can have a whole lot of distress at the end of life. Can be really awful both for the patient and for their family, having to watch them struggle to breathe. And so a lot of the management of care at the end of life is palliative in nature. All right, so this would be a time to pause for a quick get up, go get a drink of water, have a restroom break, and we'll cover bronchiectasis and cystic fibrosis really quickly. All right, go. All right, so bronchiectasis. Bronchiectasis essentially means bronch is within the airways, and ectasis is kind of a swelling or enlargement of the airways, and it's usually the large bronchi, and it's permanent and abnormal dilation and destruction of the bronchial walls, usually as a result of inflammation or infection. And cystic fibrosis in the United States, cystic fibrosis is the number one cause of bronchiectasis. In other areas, especially those endemic to TB, TB is going to be the number one cause of bronchiectasis. Like we said, it's either congenital or acquired. In the United States, more often congenital. You get permanent abnormal dilation. And it's less common because, like we mentioned, it's caused from recurrent infections within the lungs. But because we have pretty good modern day antibiotic treatments, we have less bronchiectasis as a result. You can also, the infections can cause bronchiectasis by destroying and damaging bronchial walls and interfering with ciliary action. And like we said, cystic fibrosis is most common in the United States. We mentioned these already. We said that when you have disruption of the cilia within the lung passageways, you can have problems with bronchiectasis, and Cardinger syndrome is one of those. I don't think we'd have that on our test, but it's good to kind of recognize that name. Other autoimmune disorders and other things can also put patients at risk for bronchiectasis. How do they present? What I generally think of when I think of bronchiectasis is this copious, disgusting pus that they just throw up. They do not like a little bit in a Kleenex, not like spit a couple times. It's like copious to the point of like filling up a cup of this copious pus, like foul smelling sputum. Okay, cupfuls. It's gross. Patients also have trouble breathing. They get hemoptysis because you can get, since there's inflamed and swollen or kind of dilated not dilated airways, it can kind of rupture and erode into surfaces of blood vessels. And when you have this, usually pretty frank hemoptysis, and they can present as an emergency. These patients also get persistent pneumonia. And not only do they get it as it causes bronchiectasis, but as a result of the bronchiectasis, they get more persistent pneumonia. They also can have pleuritic chest pain, weight loss, and crackles and at the lung bases, as well as wheezing. What we tend to see on imaging, high-resolution CT is the diagnostic study of choice. X-rays don't always show you a whole lot, but you can get them. What we tend to see on X-rays are these tram tracks, where you can, so normally when you see like an airway on a chest x-ray, you don't usually see the whole airway, but because in this cases the linings of the airway are inflamed and swollen, you can get these what look like tram tracks. They kind of look like, let me get my pen out. So you have an x-ray and you see these lung patterns like this within the lungs. You get these like, markings. This is the lung. Okay. On these, because you have dilation and kind of inflammation of the walls, you'll see these dilated airways within the lungs, and they'll look like train tracks or tram tracks. These dilated areas, you'll see that on an X-ray. You'll see that there. This is the tram tracks. If you look at it on a CT, because you're doing more coronal. You're doing more coronal coronal cuts. You'll see these little ring-like markings, and that's dilation of the bronchioles or the large bronchi. How do we treat bronchiectasis? Well, we give antibiotics for acute exacerbations. Bronchial hygiene is very important, so keeping hydrated, doing a lot of chest physiotherapy, percussion, inhaled bronchodilators. It's really trying to prevent the complications of pneumonia and trying to prevent hemoptysis. That's about as deep as you'll need to go for bronchiectasis when it comes to generally speaking bronchiectasis, but we will talk a little bit more in depth about cystic fibrosis. Again, cystic fibrosis is something they usually just kind of skim the surface on when we talk about testing in the pants, but we will talk a little bit about it right now. This is the last topic we're covering, so bear with me. I know we've been with each other for over an hour. It's a lot to cover. So cystic fibrosis is an autosomal recessive condition, meaning that it is genetically passed down from generation to generation. It requires two asymptomatic parents, two carriers, to have a child, and they have the 1 in 4 chance of getting cystic fibrosis. It's a defect in the chloride channels, and chloride channels are not only affecting the lungs, but they affect essentially every system within the body. So you get these viscous secretions in the respiratory tract, thick sputum, thick mucus. You also have trouble with your exocrine pancreas. You have trouble breaking down fats and foods, so you get steatorrhea, or kind of this fatty stools. You have trouble with your sweat glands, your intestines, and your genitourinary tract. So it is a multi-systemic disease, and we generally tend to think of it as a pediatric disease because back when our treatment wasn't as good, the life expectancy wasn't great for cystic fibrosis, and so we tend to see it more in the pediatric population. Usually within the lungs, we get this obstructive disease pattern, but it can be kind of obstructive in the means of this mucus forms plugs within the lungs. And after those plugs, you get these chronic infections. And so these chronic infections, and these patients tend to have colonization of more virulent bugs. So the bugs that are multi-drug resistant. And I don't know if you've ever seen, there's a movie called 5 Feet Away. I think it's what it's called. Where you see patients with cystic fibrosis suffering from having these very threatening colonizations of bacteria that can drastically reduce life expectancy. Like I mentioned, it affects other parts of the body as well. And the prognosis has improved, so we have done something right in the way of treating these patients. The median age of death is now over 39 years of age. It used to be 30, and before that it was much, much lower. Usually the patients succumb to pulmonary infections or chronic respiratory failure, cor pulmonale. What are the signs and symptoms? So most of the time, the patients with cystic fibrosis, we're going to find them out early. We do a lot of newborn screening. We do genetic screening in pregnancies that we know are a risk for having cystic fibrosis. And so most of these patients are caught at birth. But being that we live on the borders, people coming in and out of the country all the time, there could be potentially a case of cystic fibrosis that could kind of slip through the cracks. And so really, anytime you see a pediatric or an adult patient with a history of multiple chronic lung disease, multiple lung infections, pancreatitis, infertility, you should think, hey, could this be cystic fibrosis, right? It might have slipped through the cracks. You get a lot of sputum production, cough, decreased exercise tolerance, and recurrent hemoptysis. They also get a lot of rhinosinusitis, steatorrhea, diarrhea, abdominal pain because of the chloride mismatch. And they tend to be malnourished because they have trouble with fat absorption because of poor exocrine pancreas. They also tend to have digital clubbing, which is pictured in that picture there. Increased AP diameter of the chest. They get hyperresonance to percussion, and they tend to have crackles on physical exam. Nearly all men with cystic fibrosis have no infertility, and that's due to the absence of the vas deferens with azoospermia. And you can also get biliary cirrhosis and gallstones. There's a lot that can go wrong with cystic fibrosis, unfortunately. As far as lab findings, the main lab finding that they like to mention for diagnosis is going to be this quantitative pilocarpine ionotophoresis sweat test, basically a chloride sweat test. Okay, that's going to be the main diagnostic test that we do for patients with cystic fibrosis. Most of the time, this is done when patients have the suspicion as infants, neonates. But if you have suspicion, that is the test you would go for. Patients that are usually tend to be kind of in and out of the care, and so they have multiple ABGs, pulmonary function testing. They can have imaging that shows some hyperinflation and presence of bronchiectasis, like we mentioned before. A normal sweat chloride test does not exclude the diagnosis. Then you can do the CFTR, which is the gene that causes cystic fibrosis. You do genotyping and other diagnostic tests. All right. So mainstays of treatment, there's a lot going on here. I don't expect you to know all the different little things that are involved in this. It's early recognition and multidisciplinary. So a lot of different things. Most of these patients are being monitored by a regional cystic fibrosis center. This is not something you're going to manage in your family practice clinic, your mom pop family practice clinic. But essentially they use a combination of all of these treatments, which I'm not going to go into much depth with. Here's kind of a one-size-fits-all picture of what cystic fibrosis can cause. And that's it. So, hopefully we learned a lot today. It was a lot of stuff to cover. We've been with each other for 78 minutes, which is a lot of time, and I know your time is valuable. Please go back, review those, study the charts on asthma diagnosis for classification and the stepwise fashion treatment that will be on your test. Know how to treat and diagnose the COPD exacerbation, asthma exacerbation, and how the treatment differentiates from one to the other. And I think we covered a lot today. I'm proud of what we got through. There's also some great supplementary videos on osmosis, and Paul Bolin does some really great videos. So if you may be still a little bit not 100% with this Panopto, feel free to check them out. Thank you again for your attention, and I'll see you in class.